let's talk, we've hit the metastatic patient, but what about that patient that has no signs of metastases, right? We have the patients that come in and they're the 20% of patients that could potentially be a surgical candidate. So how do you work up a potentially surgical candidate when you first see them in the office? John.
So we have a fairly standard routine. The patient gets scanned with special cuts through the pancreas. They almost all get endoscopic ultrasound to try and better define the anatomy around the vessels. And then we sit in a room and all look at that together and decide, are they resectable, locally advanced, or borderline? And of course, all of those definitions change with the expertise that's in the room, with new techniques around surgical, vascular grafting. And so this is a mood of the moment, the age of the patient. So there's anatomical descriptions for what each of those is. But as I say, they've been changing. And then generally make a plan, a decision about OR right away, chemo with the hope of surgery, or chemo without the hope of surgery, or at least a plan for surgery.
Gotcha. So in your institution, if a patient's resectable, do you take them right to the OR?
So it depends if the surgeon's about to go on vacation or not. I hate to say it, but a lot of times convenience, schedules, all of these things make some decisions. Bias. I would say our plan has been, for the most part, to yes, take them right to the OR. I think given newer information around upfront chemo, even in that resectable patient, and the positives of that, enriches for a patient who's going to be a better surgical candidate downstream as well, better outcome from that surgery. So I can see over the last even 6 months at our place where we're shifting more to thinking about preoperative something or other. We've had some interesting, very short stereotactic radiation studies, some window studies that are starting to come in. So we're slowly shifting in that direction, I would say. I'm not sure it's right, but I like the idea around it. I like the idea of getting systemic therapy in early. I'm nervous I lose my window to operate. And so maybe that's not a good patient to operate on anyway. But anyway, so at least in our place, based on experiences at others, we're starting to shift.
So George, do you guys use neoadjuvant for resectable?
We were doing that more and more, I think, bringing in chemotherapy before surgery. But I think it's similar to John. It's almost whimsical who goes to surgery up front. I mean, a centimeter tumor, no real warning signs, good healthy patient probably would go right to surgery. But it is kind of whimsical how that patient is deciding which way they'll go.
So let's say you have a patient with a 1 centimeter tumor. Your baseline CA19-9 is 2,000. Do you do a staging laparoscopy?
I don't, because I'm a medical oncologist.
Dodge that one pretty well.
But they could. I think it's reasonable. I think you're looking for disease that is easily detectable and save the patient, because obviously we're not seeing it on the scan. As you know, peritoneal disease is very hard to see on imaging. So I think it's worth taking a peek. They'll do it before the procedure. They'll do it before the surgery, not as a separate procedure, not as a separate surgery day.
Have you all been seeing this? I've been seeing fewer CT chests being done.
Yes.
And pushback and having to make that phone call to the insurance company to get it. Are you seeing this too? In a preoperative setting.
Yeah.
So we are. I mean, good or bad.